So this is a practice injury scenario, so I can demonstrate how it is when you do it for real. So you would start by scanning the room. So just showing around the room, make sure that there's no notes posted anywhere, that you're not reading from anything. And all the way around, just so I can see that this is all from memory. And you're going to show your timestamp, so clearly showing the time, pausing on it, as well as the date to show that you haven't pre-recorded this ahead of time. And you're gonna state your name and student number. So name, Ken Money, I don't have a student number. And then you're gonna read what your injury information is that I emailed to you. So Jen's got a hat with a bunch of pieces of paper in it, and I'm gonna pull out my injury information. So skier catches an edge during ski race, slides into the netting on the side of the course, feels a pop deep in their knee. When examined a few hours later, there is noticeably significant swelling around the knee. It's at this point that we would start the timer once you stop reading. So Jen's going to start the timer, and you have 10 minutes to complete your injury scenario. So for the history, you're going to look into the camera and tell or talk about the questions that you would ask. And so this is to make sure that you're not looking around the room, reading off of anything. So for my history, I was told there was noticeable swelling, so already I'm suspecting an intracapsular knee injury, ACL, PCL, meniscus. So history, what happens? Where is the pain? Rate your pain out of 10. What is your 10 out of 10? What makes it better? What makes it worse? Any prior injuries? And if so, did they go for rehab? Did they feel like they fully recovered? Snap or pop? We can ask about equipment. Is their ski equipment up to date? Conditions on the course? Any allergies? Any medications that they take regularly? So that would be it for the history. We can move on to our assessment. We'll start with observation. So you get your partner or family member standing up. So knee injury, I'm going to be looking at their knees. I'm looking for any obvious signs of bruising, swelling. We know from the history they have quite a bit of swelling. We're looking for obvious deformity for the knee, genu valgum, genu varum, genu recurvatum. We can get the athlete to squat down and check to see if they're weight bearing equally through each side or weight favoring the non-injured side. Can they get thighs to horizontal? We need the athlete walk out 10 steps for our gait, and checking for any limp or inability to weight bear on the injured sides. And then we're going to move on to our non-weight bearing assessments. We'll get athletes sitting up on the edge of the table, and since I'm looking at the knee, we're going to do knee range of motion. So we can do active range of motion, active knee extension, extending one leg or one knee, and then we compare it to the other side. For knee flexion, while the athlete laying on their stomach. In active knee flexion, heel towards buttocks.
Did I just get the camera? Did I stop the timer?
No, let's flip them. So just bring that leg up again, and I measure with my fist, and then comparing to the other side. Noticeably different. And then passive range motion, we're doing it for them, so we may get some more movement. You don't have to pretend like you have the injury. Comparing to the other side. For passive knee extension, I'll get you sitting back up for me, legs off the edge. And I'm going to stabilize distal femur, passive knee extension, passive knee extension. And from here, I can do my strength testing. So try and straighten your leg out, push my hand away. Try and pull my hand backwards, good. Push my hand away. Don't let me pull your leg out for resisted knee flexion and extension. Now, normally we move on to our ligament stress test, but from my history, I saw that, or was told there was quite a bit of swelling, so I know I need to do my intracapsular swelling test. I'll have you laying on your back for me, head here. Our two intracapsular swelling tests, we had patellar compression, so pushing straight down on the patella, and normally it's a hard end feel. I'm checking to see if it's a soft, squishy end feel. First swipe test, I'm gonna swipe up the medial side of the knee with the back of my hands, and swipe down the lateral side a couple of times, and I look for that bubble of swelling to push over to the medial side of the knee. We're going to assume intracapsular swelling tests are positive, so I know it's an intracapsular injury, ACL, PCL, or meniscus. In this case, I'm going to check all three. Doesn't matter which one you do first. So we'll do ACL first. I'm going to start with anterior drawer, and normally I would sit on the end of the foot here and just pulling on their knee. Now you guys need to be able to see, demonstrate on this leg, sitting and pulling anterior for anterior drawer. For Lockman's, I'd have a roll or cushion underneath the distal femur, and I'm going to trap the femur between the roll and my hand, other hand wrapped around underneath the leg, and I'm pulling upwards on the tibia for Lockman's test. For posterior drawer, same position, sitting on the end of the leg, hands wrapped around proximal tibia, and I'm using the meaty part of my palm here to push the tibia down and back, checking for any increased laxity. And then for posterior sag, we bring hip into 90 degrees of flexion, knee into 90 degrees of flexion. I hold underneath the heel, and I let gravity act on the tibia and see if it migrates posterior. So looking for a drop off from the patella to the tibial tubercle. My meniscus test, I'll get you flipping over onto stomach. So Apley's compression, forearm resting on their foot, applying downwards pressure, and then passively, internally, externally rotate the tibia. And then for McMurray's test, the athlete would be laying on their back again. And we flex the knee as much as they can tolerate. I have my thumb on the lateral joint line for assessing the lateral meniscus. If I want to assess the lateral meniscus, I need to internally rotate the tibia, and I need to do my valgus stress pushing from lateral to medial while I flex and extend the knee. For the medial meniscus, I would sit inside their leg, externally rotate the hip, externally rotate the tibia, push from medial through to lateral while I flex and extend the knee. So those are all my special tests and my ligament stress tests for ACL, PCL, and meniscus. When it comes to palpation, I'm going to palpate the medial and lateral joint lines of the knee. I'm going to palpate the medial and lateral retinaculum, and I can even palpate on the posterior knee to feel for any swelling as well. Obviously, I'm not going to be able to palpate in on the ACL or PCL. For treatments, police are going to send the athletes to their doctor. Doctor's probably going to refer them on for imaging. MRI, they may be sent for an x-ray first to make sure there's no fracture. While they're waiting for the MRI and to see orthopedic surgeon, they're going to work on rehab, so starting to increase the range of motion and strength, balance proprioception. The stronger they are, even if they have to have surgery, the quicker the recovery afterwards. So again, police, range of motion, working on strengthening hamstrings and quads. And sorry, I skipped diagnosis, so possibilities for diagnosis are ACL tear, PCL tear, or meniscus tear. So range of motion, rolling out quadriceps, rolling hamstrings. We can massage in through there as well. For strengthening, we'll begin with isometric. So isometric quads facing the wall, trying to extend knees, but the wall is not going to move. Isotonic, our knee extension machine. And for eccentric, both legs in the knee extension machine. Take the non-injured layout all the way on the injured side, lowering it down. For hamstrings, isometric, laying on the ground, heels on the couch, pushing downwards into the couch. Isotonic would be our hamstring curl machine, and eccentric would be our Nordic hamstring exercise, kneeling on the ground, slowly leaning forwards. After strengthening, balance proprioception, so standing on solid ground, two legs, we can have them eyes open, eyes closed, add in some perturbations, trying to knock them off balance. Then we move on to single leg on solid grounds, and then we gradually put them on more and more unstable surfaces. So standing 2 feet on a mat, move the single foot on a mat, eyes open, eyes closed, balance board or rocker board, Bosu ball, we get round side up, round side down, and just gradually increase the difficulty. Running progression, we're gonna do pool running, deep end, then shallow ends, move on to softer surface like a turf fields, jogging, slightly faster running, and adding in cuts as well. Now if they've had surgery, they're gonna want to start to run around the 3 to 4 month mark. We're gonna hold them back. After running progression, return to sport, light drills, harder drills, light contact, harder contact, return to sport. They may want to brace on return to sport as well. That is 9 minutes and 43 seconds. One other thing I forgot to mention for meniscus tear is open chain exercises initially, so it's still within the 10 minutes, that counts. So if you forget something from earlier on, you forgot a question you wanted to ask, and it's still within your 10 minutes, you can go back and ask a question from the history. If you forget a test that you want to do, you're already describing your treatment, and you forget an orthopedic test, you can go back and do that. I don't stop marking until your 10 minutes are up.